Connecting has begun.
Good morning, everyone. I just want to welcome you to today's webinar. We are so glad to have you with us today. My name is Jordan Baker-Friend, and I'm with the University of Nevada School of Medicine, and I'm here to introduce our speaker. Our speaker today is Trey Delap. Trey Delap is a 25-year resident of Las Vegas, where he earned both his bachelor's and master's degree at the University of Nevada, Las Vegas. His graduate degree is in Ethics and Policy Studies with an emphasis in medical ethics. A committed advocate for social justice, Mr. Delap's professional and volunteer experience has always included service to the community. He is currently a director at Group 6 Partners. This program is brought to you today by Join Together Northern Nevada and the Nevada Statewide Coalition Partnership. Thank you so much for being with us today, Trey. And I just wanted to show you our learning objectives today and our disclosure policy for the University of Nevada. And we're just going to welcome Trey right now.
Thank you so much, Jordan, and I want to thank the School of Medicine and Joint Together Northern Nevada, as well as the Nevada Statewide Partnership, for inviting me to present this webinar on the Prescription Monitoring Program. The topic today is Prescription Monitoring Program, Clinical Utility and Patient and Provider Reports. We just worked out, so I can now advance the slides. The prescription monitoring program has been in place for a number of years. It was innovative in Nevada in the mid-90s, in 1995, 1997. And essentially the prescription monitoring program is an electronic statewide database of controlled substances. It's operated completely by the Nevada State Board of Pharmacy through the Controlled Substance Abuse Prevention Task Force. For as long as the program has been in inception to creation, the Controlled Substance Abuse Prevention Task Force is a group of leading stakeholders in the state that observe, monitor, and advise for the development of the program. It's gone through a few changes in the time that it's been in place. It's gone through some vendor changes, and currently now we have a very accessible online database that monitors prescription drugs in the state of Nevada. One thing to remember is that the prescription monitoring program, and it's also called in other states the prescription drug monitoring program, I've chosen to just refer to the prescription monitoring program for the purposes of this presentation, is that it's monitoring controlled substances exclusively. So it only monitors prescriptions that are filled in Nevada pharmacies or dispensed by authorized dispensing practitioners in the state for controlled substances. So it's not monitoring every single medication that's filled in the state. It's just monitoring the controlled substances. Across the country, PMPs have taken over and are active in all states but one. And this graphic that is available now shows that the spread of the prescription monitoring program throughout the country. Most recently, Nevada's PMP has joined the Interconnect, and what that does is it provides an opportunity for anyone who's querying the PMP in this state to query 28 other states simultaneously. So if there's a new patient to the practice that may have moved here from another state, or is in our population centers with Las Vegas and Reno, we are certainly have a lot of people that may live or reside or work in a border state. So this interconnectivity is an excellent innovation that increases the utility of the PMP for our prescribers in this state. There's emerging evidence demonstrating that PMPs are effective in reducing diversion of opiates as well as overdose deaths. So we look at this graphic and we see that in New York, after 2012, they required all prescribers to check and utilize the prescription monitoring program in that state. The result that they identified was a 75% drop in patients who were seeing multiple prescribers. This is a key component in identifying potential diversion. Diversion is characterized by people who are receiving medications but not necessarily using them for themselves. They may be selling them or distributing them in other ways. So two key things that the PMP looks at is identifying multiple prescribers as well as identifying multiple pharmacies. And the term usually used for that is polypharmacy. In other states, in Florida, in 2010, they required utilization of the PMP because they had a major problem with pain clinics, and they saw a 50% decrease in the overdose deaths related to oxycodone. So one of the other benefits to the PMP includes a evaluation by the clinicians from the prescriber to the pharmacist in who is obtaining drugs and how much. This is another piece that is very relevant to the clinical picture of the patient when the practitioner or prescriber is considering writing a prescription for opiates. And again, this graphic shows that there was a 50% drop in overdose deaths. That is part of the public concern and problem with the widespread opioid epidemic, is that many people are dying from overdoses from drugs that weren't prescribed to them. And the PMP is a tool to help clinicians and pharmacists address that issue. In Nevada, I'm using the Board of Medical Examiners. I understand and I want this presentation to apply to anyone who's prescribing controlled substances, and that could be a podiatrist, a dentist, anyone with a controlled substance certificate in this state. But just as an example, using the Nevada State Board of Medical Examiners, this is the allopathic board that licenses MDs. They adopted, by reference, the model policy for the use of controlled substances for the treatment of pain. This model policy was developed by the Federation of State Medical Boards. It's a professional association that represents the state medical boards of the United States. So one of the features of adopting a policy by reference is that when there's an update to the policy, sometimes the regulation has to be updated. This is and I've cited here on this this slide, this is in Nevada Administrative Code, so it's regulation to clarify a statute. And this is included in the Nevada State Medical Board's Standards of Practice Code of Regulation. So things have changed in that the policy has been updated and renamed. So this is one of the challenges that happens when you adopt a policy by reference. If they change the name of it, you have to re-reference it with the new name. And so the question was to the medical board, had they done that? And they have done that. They have amended NAC 630187 to include the new reference to the Federation of State Medical Boards guidelines regarding opioid analgesics in the treatment of chronic pain. Because this is in regulation and considered part of the standards of practice, the intention of the medical board, it is assumed, is to provide guidance for both the practitioner and the licensee to ensure that they are prescribing in a manner that is acceptable to the standards of practice. The next slide outlines the key components that incorporate an emphasis on the prescription monitoring program in the model policy on the use of opioid analgesics in the treatment of chronic pain. This, of course, is available if you go to the Board of Medical Examiners website. They will obviously link to the Federation of State Medical Boards policy that you can review and access for yourself to see what key components they include. The PMP, or querying the PMP, is only one of a number of different things that they are advising that is part of a good clinical assessment and documentation of opioids used for the treatment of pain in a clinical practice. So the Federation concluded in their Policy Academy that the goal of this policy is to provide state medical boards with an updated guideline for assessing physicians' management of pain, so as to determine whether opioid analgesics are used in a manner that is both medically appropriate and in compliance with applicable state and federal laws. This is the position that is happening, that there is a proper use of opioids in the treatment of pain, there is a concern that there is diversion of the drugs, and that is creating a public health issue. The pervasiveness of PMPs across the country that we saw in the earlier slide, where they're available in every state except one, makes this a valuable clinical tool. And also the emerging evidence is showing that this surveillance tool is a complement to the physician's practice. So in continuing, the prescription drug monitoring program is an integral part of the model policy. So if you are treating a patient for pain, or you're using opioids in the treatment of pain, and it goes both ways. That is one of the main shifts that occurred when they renamed the policy. Instead of just dealing exclusively with controlled substances, they expanded to if you're using opioids. And there are they are establishing clear modalities and reasons for using opioids in practice. So this isn't intended to limit the available tools to the clinician in the treatment of pain. It's just to increase the monitoring of those programs so that they can be assessed on a public health and a regulatory compliance. So the PMP, in addition to providing individual clinical information, they are also capable of providing good community-level surveillance data for public health. And that is where they derive the earlier statistics that I mentioned regarding the impact of the PMP in the states that it was mandated. So in preparation for this presentation, a bill had become a law, and we all remember the song, How a Bill Becomes a Law. Well, SB 459 was introduced in the Senate, and it passed the Assembly and was signed into law by the governor. This is this particular piece of legislation has a number of different provisions dealing with the opioid epidemic in the state, but the piece I want to focus on for purposes of this presentation is the requirements to at least register with the PMP. So many prescribers, anyone who holds a controlled substance registration in the state, should be or is able to sign up for the PMP. With the enactment of this bill, it's now required that if you have a controlled substance registration and you're writing for controlled substances, that you at least register with the PMP. And there isn't a mandate to query it at this time, but that is being considered in other legislation that hasn't passed as of this moment. But as we know, the legislature is in session right now. So some of the utility for accessing the prescription monitoring program for Nevada is that by accessing it and documenting that you have queried the prescription monitoring program, you are complying with the standards of practice codified by the Board of Medical Examiners in NAC 630. So I will show you later in the presentation how to query the report and how to run one off, print it out, and then you can include it in the patient's chart, whether it's electronic. Then you can document that you had queried the PMP prior to writing the prescription, or you're at least monitoring it along the way. So this also is a good piece of information to add to a medical record. Especially with a new patient that's new to the practice, you may want to know what prescriptions they've been on before, and the PMP will give you at least a snapshot of controlled substance prescriptions that the patient may have received. So one of the things, again, that was, as Jordan mentioned, my background is in ethics, and I did a lot of research focusing on the clinical encounter and the morality that interacts with the physician and the patient. So one of the ethicists I thought was most relevant to this topic that I wanted to bring up here is ethicist John Ladd, who articulated what's called the problems approach to clinical medicine. And it's outlined here on this slide. For example, when a patient is in pain and seeking relief from a clinician, both have the same problem, the patient's pain. Both share the goal of relieving the pain. However, both approach the same problem differently. This is intentional. We seek out, and our patients seek out, clinicians, people who are trained in a scientific and clinical approach to the identification of the challenge of whatever's causing the discomfort or pain or impairment in life. So the reason that I mention the problems approach is that the patient is experiencing the pain or the infirmity or the effect of the infirmity. So the patient is the best authority on what the pain is and what the problem is. The clinician then is tasked with using the tools of clinical medicine, clinical assessment, and science to identify the source of the pain. So essentially, both are attempting the same goal. The patient would like to be relieved of pain. The clinician would like to relieve the pain, and therefore they are both sharing the same goal, the same end of the clinical encounter, the same noble end of the profession, but they are approaching it at a very different point of view. And that's something that we carry in clinical medicine, and we see it all the time, that, again, sometimes it's a little frustrating to explain things to patients when we're speaking different languages. So, for example here, the graphic on the bottom shows the patient experiencing pain. Looks like she's in pain, but we have a clinician who's going to take a more clinical approach to the evaluation of the pain. And then I like this little cartoon here. Skip all the medical mumbo jumbo, doc, and just give it to me straight. What is ICD-10 code for this? So sometimes patients aren't interested in the details of why they are experiencing pain, and sometimes they may not be interested in understanding the nuances of science, and also we don't want to go there, then that will certainly scare patients or whatever. So this is a way of understanding and accepting that the job, even though the clinical encounter is where the physician and the patient get together, the same problem is approached in different ways by both the patient and the clinician. And of course, this is a classic. We can't move on without not saying this. When you hear hoofbeats, think horses, not zebras. That's an adage from medicine, and anyone with some experience knows the origins of that. So moving on to the clinical utility of the PMP reports. A query of the PMP will give the clinician a more complete picture of the patient's history of treatment with controlled substance prescriptions. I translated all those HXs for those who may not have a clinical background. This also is important to establish the opioid tolerance of the patient. In some cases, and the term is often used as opiate naive, when a clinician initiates a treatment with opioid therapy, if the patient has never had any experience with opiates, that may change the clinical picture as far as the dosing. And some studies have shown that doctors or clinicians will change their dosing based on information they've gotten out of the PMP. To be clear, and to emphasize this point emphatically, the PMP report is an adjunct to the clinical assessment and treatment. It is a piece of information that is just like a record from another provider. It's just like a lab report. It's just like a piece of information that will either verify what the patient is saying. It may complement the thorough history of a new patient or a new treatment modality, but it's certainly a tool that's valuable and it's accessible to anyone who is interested in learning more about their patient, generally speaking. Some patients don't have a good, clear medication history. They may not have known that some of the stuff they're taking is a controlled substance. So the PMP is, again, a good clinical adjunct, especially for a patient that's new to the practice. So we have expanded the PMP to a multi-state query. And in Nevada, Nevada is, again, one of the 28 participating states with the interstate query available. So you can run reports from people who have moved from many of the participating 28 states. The type of medication, again, that was recorded in a PMP is just controlled substances. And it's any controlled substance that's been filled in a Nevada pharmacy or by a dispensing practitioner. So if you are a practitioner who dispenses or uses controlled substances in your practice, there are some reporting requirements, and the Board of Pharmacy is the entity that would enforce that, because that authority is based on or derived from your controlled substance registration rather than your medical license. So that's where the medical board or your licensing board is one source of information, of course, but this is another thing that's run by the pharmacy board. Another tool of the PMP is the public surveillance, and through monitoring of controlled substances, public health is maintained by increasing opportunities to identify misuse of medication. This is at the heart and soul of the PMP and its original intent. The intent of the PMP was to create a tool that would present information to a dispensing pharmacist or a prescriber that if a patient may be receiving medication or controlled substances from multiple prescribers or multiple pharmacies, again, polypharmacy, and these are key indicators of potential misuse. So it was always intended to be a guide, and it was always intended to alert the clinician or the pharmacist that there may be another issue here, because a patient that is diverting medication has another kind of issue that can be dealt with. It could be addiction, it could be diversion, it could be a variety of other things, and this information will help both the clinician and the pharmacist understand their patient picture better. And this tool is just a complement to that. PMPs promote professional collaboration, prescribers and pharmacists. The pharmacy board explains this well, and their website has some good information, and also the National Association of Boards of Pharmacy has good information on the overlapping liability that exists between a physician and a pharmacist. The pharmacist is responsible for making sure that they are dispensing the right medication every time, all the time, and the physician or clinician or the prescriber certainly hopes that the pharmacist is a double check on the system, because busy practices, things can happen and medication errors get caught. This is another tool, and it's focused on controlled substances, and it promotes collaboration amongst the professions. Anything that's in the PMP is considered protected medical information, guys. It's intended, and there's very limited access to it, and the pharmacy board is doing an excellent job at ensuring that only those who should be querying the PMP are, and because again, this information is protected medical information. It's just like a medical record from any other provider or any kind of report that you would put in a patient's chart. This is a critical piece of information, and it should be protected as such. So the good habits of protecting health information should be applied to anything that comes out of the PMP. This is, of course, complemented as well. The PMP monitors all controlled substances distributed in the state, as well as the interconnect states, which are the 28 states. So it has pretty good coverage and pretty good information. Can't make this point strong enough that the integrity of the medication system is strengthened by monitoring. So you can, if a clinician writes a prescription for an opiate or a controlled substance, any controlled substance in the schedules, then you can verify that that patient filled the prescription. It also, and we'll get into that a little bit later, it also gives you good information about the use of your prescriptive authority. This is one of the things that's also important, is that as a clinician licensed in this state, you have multiple licenses. You have your professional license that you got from your medical board or the board of podiatry or whatever the licensing authority is. The authority to write prescriptions comes from your registration with the Board of Pharmacy, and then the authority to write controlled substances comes from the Board of Pharmacy as well. And there's also a federal component if you have a DEA registration. So there's all these levels of registration here, and we want to make sure that since we have so many levels, there's a good reason for that. And this, the PMP will help ensure that your authority that you're responsible for is being used properly and in accord with your directions. So to set up an account really is extraordinarily simple. It's a process of basically going to the website, the NevadaPMPAware.net. This is easily linked through a variety of different sources. The Pharmacy Board is a good source because that's one of the main portals for the PMP. Also, healthiernevada.org has a lot of up-to-date, relevant information that is valuable to prescribers, and also it has a link and some demonstration on exactly what you'll need. So you can print out those instructions and you can use that information in preparation for setting up your PMP account if you don't already have one. But of course the first step is to enter an email, and this is, if we're dealing with clinicians that don't have email addresses, well, this is time to get one. So go get an email address because we will need this, of course. At this point you would enter an email address and a password, and then you'll get an opportunity to confirm the healthcare professional. So this is because now there's a variety of healthcare professionals listed on the left of the screen here, and includes, of course, physicians, dentists, nurse practitioners, physician's assistants, et cetera, pretty much anyone who would have a controlled substance certificate, and any other person that might have access to the PMP. These screens are where you can select your particular role. So the first step, of course, is the holder of the controlled substance registration. That means the physician themselves, or the nurse practitioner, or the podiatrist, or whoever has the controlled substance must initiate the process of signing up, or delegate it to a trusted friend that works in the office. So this is the essential information that you will need, and it's good to see this. And again, if you go to these other resources that I mentioned, healthiernv.org, or the Board of Pharmacy website, if you have this information prepared and ready to go, then your registration process will go so much quicker. So they will need your DEA number, they will need your national provider number, your date of birth, the prescriber's date of birth, the driver's license number, and the Nevada Controlled Substance Registration number, and the professional license, and you need to designate the type. If it's an MD, then it's an MD license. If you're a DO, then it's a DO license, and et cetera. And then the Controlled Substance ID. It seems like a lot of personal information, but this is part of the very strict and very comprehensive validation program that the Board of Pharmacy does to protect the integrity of the PMP. Again, this is protected patient information, so they are very thorough in who gets to have access. They want to make sure just those who are supposed to have access, and that's why they verify each one of these data points. So what will happen, like always happens when you forget your Amazon account or whatever, you will have made an error in designing your password or something. So this is an example of a password that would work. It includes I use this slide on purpose to show you the problems that can happen. You must have an 8-character password, but here's an example of one that will work. It must have a capital letter, it must have a number, and it must have a symbol. So it will continue to kick you out until you get a password that's fixed, that meets their criteria. The first thing that will happen is you will get this very plain email that looks like this. I've circled the part at the top that shows you what it looks like in the subject line. And then it says this is a verification email, and then you must click to verify the email. This is just like anything else when you get an account somewhere. They want to verify that the email is a real email, actually works and goes to a person. So this is step one. So you verify your email, and this must be done by the prescriber, the person with the controlled substance registration. After you've verified the email account, there will be a paper form that you have to complete and upload, fax, or email to the PMP. This is an agreement that you understand what the PMP is and you will use it accordingly. Then you must have a modicum of patience because, again, this is done by a human being at the Board of Pharmacy who will verify the account to make sure that everything is appropriate, that they are granting access to this information. As you can understand, a database that includes every controlled substance that's been filled in the state of Nevada is a massive database with a lot of protected health information. So they want to make sure that that information is going to the right people. When your account is activated, you will be notified. So this is the thing that happens. The account can't be set up instantly. It will take a couple of days, not very long though, for them to verify that all this information is accurate and up to date, and that then they'll activate your account. Then you're good to go. All you need is internet access and a website. Oh my gosh, I do not have time to query the PMP on every single one of my patients. I am so busy. That's why we have the delegate function, and this is an incredibly valuable piece of the prescription monitoring program. After you have established your PMP querying account as the prescriber, the holder of the controlled substance registration, you may then set up a delegate account, and you can have up to 2 delegate accounts under the prescriber. Now, this is the person in your office who is you trust well in your back office, or is a part of the registration process or the new patient process, and this person can log in under authority with a separate email, but it's connected to the original account, and then they can run the PMP queries for you. You then, as the registrant, the person who holds the account, even if you've identified delegates, you may then check to see how often someone is querying the PMP under your registration. Once you get, this is a sample of what the form looks like, and this is the actual form that has to be signed by the person with the controlled substance registration, the prescriber, either the physician or whoever. You'll get this form, fill it out, send it in, upload it. I mean, it is a paperless system, and once that's in there, that's in there. And then they'll give you a thank you screen, because the people at the Board of Pharmacy are very, very helpful and very, very polite. So this isn't a horrible process. It's actually very simple. So part 2 of this presentation-ish is how to query the PMP and what you get from, what kind of information you get. So once you have an account that's been approved and validated by the Board of Pharmacy, there are 2 types of queries that you can run. One is the patient query, and this is, again, you have a new patient new to your practice and you want to just get a piece of record. It's just the same as if you would you receive a new patient, you would want to query, get a copy of their charts. You know, anytime a practice shuts down or whatever, the transfer of charts occurs and you need your medical records, then PMP is there too. You can also verify or check your own usage. So when you go to the NevadaPMPAware.net, that's the website that's just for the PMP, simple login, very simple screen. They've kept it very clean. You put in the email address, you put in your password, and there you go. You'll be logged in. Oh, I'm going the wrong way. Here are the data fields that you will need for a patient. Extremely simple. You need the patient's first name and the date of birth. So to recap how simple it is, you need the patient's first name, last name, and their date of birth. And with those data elements, you'll be able to run the PMP. In many cases, if someone hasn't received controlled substances in the last 6 years, then it won't generate a report. So often you'll get a no report, no report. Even if you get a no report, it's good to hold on to that, make it part of the patient's chart. Then you'll have verification that you actually queried the PMP. So even if there's no data in the PMP, you will get a form that says there's no data in the PMP. After you enter the patient's first name, last name, and their date of birth, then you would enter the date. And this is, I need to update this, it's 6 years, not 2 to 3 years. So it will default to whatever date you want. So I would just put 2000 and it will default to whatever. Then you'll capture the whole picture of as many records as they have that go back. This is what the screen will look like on your computer when you run a patient query. So we had patient Cicero Conroy, name, birth date 1/25/32, and this is what Cicero Conroy has been given. So it shows the date filled, it shows the date it was written. So here we can identify if there's a disparity between how long did you have this script before you filled it. It shows what it is, how many, and based on the instruction, the SIG, you'd see how many days this was intended for. This is the name of the prescriber, this is the prescription number, and this is the pharmacy where the prescription was filled, and this is the number of refills written on the prescription. How was it paid for? It was commercial insurance. So if we have an insured patient, then this may be exactly what they say. Now we know. We have a different doctor, same pharmacy, different medication, commercial insurance. So the things that you might be looking for here are frequency, and in this field, prescribers. This is multiple prescribers. But down here, and I'll show you this in the next report, it'll show also the list of all the prescribers that have written controlled substances. This, I like to point out, you can download the report in a clean-to-print PDF format, portable document format. This is a nice, clean way if you're printing things out for the clinician to look at, or you want to print it out, or you want to upload it to the EMR or EHR, then the PDF is a good way to do it. And if you want to analyze it in some way, CSV would be what you would download if you were going to upload something into an Excel spreadsheet because you wanted to identify some trending. This is what the PDF report looks like. There's our patient record, and verified, and here's a list of all the prescribers. Here's a list of all the prescriptions. And this is something that you could print out and again put into the patient's chart, and we are good to go. I've mentioned this numerous times. It's helpful in establishing new patients. It's also helpful if you are establishing a new mode of therapy that includes a controlled substance. That is an interesting nuance of this epidemic. You will have a patient that is an established patient that something will have happened, and now there's pain, and now you're treating the pain with an opioid analgesic. Even though you've known the patient forever, this is a good way to establish that you are following the guidelines, and you will, if ever need to, who knows why you would ever need to, if there's a regulatory compliance check, there's a liability concern, you will show that even if it was just that one bad winter when a clinician decided to write for hydrocodone for a cough, you've established that you have checked to see that this isn't polypharmacy, this isn't doctor shopping, this is a verifiable use of an opioid analgesic, and it takes 2 seconds. Again, it's good for new patients that are new to the practice. It's also good for established patients where you are beginning a new mode of therapy that includes controlled substances. And of course, that includes any controlled substance. There's a lot of information about benzodiazepines and other medications. Anything that's in the controlled schedules will show up on the PMP. So that basically concludes the technical portion of this presentation. I put this slide up here so that we can have reference for technical information with the Board of Pharmacy and the people who run the PMP. They are your go-to if you have any questions about how the system works. You can't log in, you forgot your website or your login address, you forgot your password, you can't set whatever is going on, they will be able to help you. And they are extremely available. They have a staff that is committed to this, and they have both IT help and technical help. So this was an introduction to the Nevada PMP program. I hope that we addressed a lot of questions. If there are questions that have arisen, I'd be happy to do my best to answer them.
If anyone does have questions, please feel free to put them in the public chat on the bottom. You can just go ahead and type those questions in.
What is currently required by law in Nevada? And this of course depends on your level of registration. If you are a clinician and you write for controlled substances, then you have a registration with the Board of Pharmacy to write for controlled substances. With the change in SB 259, and I'll speed on back there, if you have a controlled substance registration with the Board of Pharmacy, now you will need to establish an account to query the PMP. And this is the law that references that. So this was passed April 30th of 2015, SB 2459, and this is the section that outlines that. There are other bills pending in the Nevada legislature right now that will require at some interval that someone actually query the system. And again, it's a good opportunity to check to see if your access has been compromised. But the law currently in Nevada is that if you have a controlled substance registration, and this is brand new law, so the boards are going to have to work out how they're going to enforce this. The law then will be that you need to have access to the PMP. The question is, does the database include VA pharmacies dispensing in Nevada? And the simple answer is no. Not at this time. As we understand, practice of medicine, practice of pharmacy, everything that happens with the VA on VA property is federal. So at this time, they are not required to report to the PMP or query it, and that's because they are outside of the jurisdiction of the state. So there's a question about Section 639 is that the Nevada Revised Statute or the code, and it seems to suggest that the patient utilization report is required prior to prescribing. It does seem to suggest that. In some cases, there's been some speculation that the requirement is if you have a reasonable suspicion that the prescription is being solicited for diversion, or the patient may have an addiction or emerging addiction or something that good cause appearing, you should query the PMP. Whether or not they're going to sanction you for not doing that, perhaps, but again, if we're looking at this NRS 639-2507, it's being amended to include these sections. So that's one thing to look at. If you have access to the internet, you can go look at Senate Bill 459 and see the exact language. Again, this will be, this is the new law, but it will be explained in detail through regulation most likely. And again, 639 is a pharmacy board statute, I believe, so they will be the ones that will promulgate the regulations and handle that. Can the report be shown to the patient if he requests to see it? Well, that is an interesting question. It is a piece of medical information. What's sort of interesting about this is that the patient does not have access to the PMP. The patient can contact the pharmacy board and request a copy of their PMP, and the pharmacy board will accommodate that. They will need to deal directly with the pharmacy board. Now, should a patient see their PMP report? Perhaps. I think that is really at the discretion of the clinician. If we consider the PMP report just like any other piece of medical information, like a radiology report or a record from another practitioner or a lab value, then I think it's within the discretion of the clinician if they want to show the PMP report to the patient. I would think, and this is a bit of my opinion, if I was a patient and I requested my report, I would think that you would want to give it to me. But I don't believe, and I'm not aware of a requirement that you have to turn it over to a patient. What can happen here, and again, the intention of the PMP is to provide information to the clinician and the pharmacist. If it's identified that you have a patient that might be diverting or teetering on the edge of an addiction, one thing that you might want to be prepared for is how are you going to handle that awkward conversation. If a patient is diverting medication, they're committing a crime. And that is something that can be avoided. There's some criminal pre-intervention. The pharmacy board can advise on this process if you suspect someone of diverting their medication. But if someone is suffering from an addiction, then that might be another type of conversation. The guidelines recommend, and especially people who practice pain management, they have a mechanism in place. They at least have contacts in place where they can direct the patient to clinical care for another issue if they have an addiction issue or something like that. One thing I wanted to mention here, and I think I forgot, but what I'm demonstrating on the slide right now is the history of requests. So that is where you can run a report on yourself. If you are a registered person, you can see how many patients have been queried. You can double check the work of your delegates. So this will show you if, let's say, it becomes required that you have to query the PMP on a regular basis. You go here, click this, and it'll show you all the ones that you've done. Will all 50 states be on the system in the near future? There is a desire that's being established by national policy. The Office of National Drug Control Policy promotes the prescription monitoring program in all 50 states. As of now, the only holdout is the state of Missouri, and they have not passed the law. Every other state either has a functioning PMP or they have empowering legislation that will create the opportunity for the PMP. Many states who don't have active or up and running PMPs right now are able to apply for a variety of different grants to establish their PMPs. And it's interesting, actually, this is just sort of general information about, like in most states, about 25 states, their PMPs are run through the boards of pharmacy, like our state. That's the same as it is in Nevada. In some states, it's run through the state's Department of Public Safety, and in some states, it's run directly by law enforcement. And then in a handful of states, it's run through their DHHS, their Health and Human Services. So I can't say for certain that all 50 states will eventually be on the system, but there is a lot of support and resources available to promote PMPs in states. Especially what is happening now is there certainly is a push to connect regions. The state of Kentucky was very excited when all their bordering states were connected because they had a lot of border issues where people were living in other states crossing the border just for prescriptions. But that's an interesting question. Also, an innovation in the PMP and some of the components that they're looking at is the PMP is a good public health surveillance tool. So in looking at, and there is data that goes both ways on this. There is some data that shows the PMP is not a really good tool for public health surveillance. There's data and studies suggest that it's an excellent tool. So what is happening with an emerging motivation to address a public health issue like opiate overdose and addiction and misuse, there will be some policy pressure to do something. And establishing a PMP is an excellent way to surveil the state as well as providing for clinical information. And again, the preliminary data is showing that there's efficacy when the PMPs are utilized.
Well, it seems that most of our questions have been asked at this point. We're going to keep this chat pod here, and Trey is going to be here for just a few more minutes. We have him until 1. So if you have a couple more questions, we've got a few more minutes, so go ahead and type those in now, and then we'll move on to the page where I can show you the evaluation for your certificate. I'm going to echo Jennifer's thank you. Trey, we so appreciated having you today. It was such a great presentation, very practical. You explained things very well, so we appreciate your time today. Thank you so much. And thank you to our participants. We so appreciate you being a part of this program. I wanted to help direct you to the evaluation link. It's down here at the bottom, right here for the SurveyMonkey link, and you'll be able to put that into your web browser and finish the evaluation. Just a couple of questions. It'll bring you right to the certificate page, so you can claim your CME credit. This does count for ethics credit for your Nevada ethics that you need to complete. Our presentation notes are available down on the bottom right-hand corner, so you can download that file if you wanted to keep track of the notes that he was talking about today. I also wanted to let you know that we have 3 more webinars in this Prescription for Addiction series. You can register on our website for these different webinars. We have a couple other programs that you might be interested in. There's an opioids program on June 25th. We have our Nevada Cancer Control Summit on September 17th and 18th. And our Nevada Public Health Association annual conference is on September 24th and 25th. So if you'll visit our website, it's at medicine.nevada.edu/CME. You'll find all of the information that you may need on that site. So we'll also have that up in the chat pod. We'll go ahead and put in that link so you can link there. But thank you again for your time. We're going to leave this page open for about 10 minutes. So if you need the next 10 minutes to click into the evaluation and complete your evaluation, we'll leave that open for you today. I just wanted to let you know about our upcoming webinars. Maybe some of you haven't seen the titles for those. We have one on Monday. We have Dr. Howard Chin coming. He's going to be talking about non-pharmacological management of pain. So that's on May 18th. And then June 16th, we have one called Youth Trends. Youth are using what? So if you're someone who deals with youth and is needing to know what they're using these days, that's on June 16th. And June 17th, we have a webinar called Pharmacology of Marijuana. And so you can also register for that. So thank you so much for your time today, and we'll leave this page open for you.